Hello, I'm Joshua Freitas. I'm going to be talking to you about a critical care case study about respiratory distress. So this is for my Evidence-Based Practice 2 course for my Bachelor's in Science of Nursing with Dr. Carol J. Neal at Florida State College at Jacksonville. So we're talking about critical care here. Critical care, progressive care unit in particular, is a step down of the intensive care unit, still considered a critical care unit. This is in between medical surgical unit and the intensive care unit, where you have 3 to 5 patient ratio to each nurse here. And very focused on cardiac, but I get a lot of critical care instances. Just like any other hospital unit, we have a multidisciplinary team approach with doctors, nurses, social workers, CNAs, respiratory therapist, and of course all of our other therapists like physical, speech, and occupational. These are pretty standard across the hospital on all units. So our case study is Mr. M, who's 70 years old and admitted for COPD exacerbation. So of course this is not his first go around with COPD. He's 70 years old. He's had it. He's got a history of CHF. He's a current smoker. Hypertension, CAD. He's O2 dependent at home, and of course he has the history of COPD. Basically, we noticed on the monitors that our patient is desaturating down to 85%. He's on the 2 liters nasal cannula. His respirations are 35, heart rate's 124, and blood pressure is 190 over 84. The nurse goes in to check on him and finds the patient short of breath with altered mental status and pulling off his nasal cannula, unable to coerce him into relaxing and keeping the nasal cannula on. With assessment, we have coarse crackles in the upper lungs and diminished lung bases. The nurse tries to keep patient in bed with the nasal cannula, and of course he's aggressive and fighting off because he's hypoxic. So physician orders non-violent restraints, non-rebreather, arterial blood gases to check his O2, CO2 buildup. We have Lasix, 80 milligram IV stat, chest x-ray, and BNP. So the Lasix should pull off that fluid that's building up, and they're going to check out, see what the fluid's, what it looks like in those lungs. So question 1, is it ethical to restrain Mr. M while he's having this exacerbation? And the answer is yes. The CPI recommends that physical intervention be used only as a last resort when a patient has become a danger to himself and others, and the least restrictive intervention must be used as possible. So we would use soft restraints on Mr. M, and of course, he's a danger to himself and the staff. So we're going to restrain him so that we can try to give him some oxygen and get him feeling better here. So after all the interventions, non-rebreather and whatnot, altered mental status is still present. His ABGs come back, 7.1 pH, 81 CO2. The PO2 is 112, and the HCO3 is 25. O2 still 85%. Respirations are 38. Heart rate's 124. Blood pressure is still the same at 190 over 85. Chest x-ray shows pulmonary edema and BNP of 1,000. Okay, so he's still having an exacerbation. Call the physician back and get the patient on BiPAP, basically, along with a scheduled Lasix to pull off the fluid. We're going to monitor closely, and we're going to do ABG and chest x-ray in the morning. Continue with the restraints so that he can get the most out of the care right now. Conclusion, in the morning, they find that the patient is back at baseline, and he will continue to stay for his original problem. He'll have in the morning he's able to get the BiPAP off, get the restraints off, and is back on 2 liters nasal cannula at his baseline for his hospital visit. So we can see that respiratory distress is a dangerous thing and can be fatal if not treated. But if you have good nursing intervention and you get in there and get a hold of the doctor in a progressive care unit, you can take care of this. Maybe in a med-surg unit they may have rapided and sent up, but it's manageable in a progressive care unit when you only have 4 patients. And here's my references, and thank you for watching.